Good morning, YouTube. We've got a full day of cash PT today. I think we've got about 7 or 8 clients, all with very different presentations. It is very icy here in Idaho today, so hopefully we don't get any cancellations, but you know, it's something we can't really control at the end of the day. My first patient of the day is a semi-pro football player. Him, I'm not sure what he's gonna kind of want to work on, but we work a little bit more for hips, SI joint. He's had reconstruction on his feet, those kind of things. Second patient is a pinched nerve in his neck. Third patient is rotator cuff tear of the subscap. Fourth patient is a hip flexor tear that actually went to other physical therapists and they just told her it was a strain. She's had a lot of pain for a really long time, so it's kind of a fun one. Then I have lunch. Then my fifth one is more of a older adult dealing with some back pain, but she is a power lifter, very older power lifter here. And then we also have, I've been a personal trainer for 10 years, but I don't really do it as much anymore because obviously my time. My last 2 are personal training clients, so that'd be kind of cool to see too. So I've got a totally different layout today of all different patients. So let's get it started.
Tell me what you sipping on, baby. Take it to the body shop, crazy. Love how you move it like that. Say a friend, and she like it like that.
My first patient came in with a new hip flexor strain, so we did some reassessments before going into some manual release of that TFL muscle, where I'm just tacking that muscle belly down as we bring it into internal, external rotation. Then before we get into some more manual release of that hip flexor, really targeting that iliopsoas, that deepest hip flexor. Then we went into a belted range of motion technique. This is called Mulligan mobilizations. It's a very old school physical therapy technique, but it's very effective. We're really just trying to distract that joint from its socket as we bring you more into internal and external rotation to open up those hips. Then we went into further stretching those hip flexors before we go into a little bit more exercise. We had a little PNF technique, contract, relax, to deepen that stretch. We started off with some isometrics first, just kind of gauging and seeing how much pain he's in, but he had no pain during these isometrics, so then we kind of graduated to a hip flexor pull through. He's familiar with this exercise, but we're really stabilizing a little bit more so with the opposite leg as we drive that hip into hip flexion. We then went into some lying leg raises with a band to get a little bit more weight with it as we control that eccentric throughout the entire range of motion. All right, so Steve here, he came to me kind of dealing with a lot of pinched nerves. Numbness tingling all the way down the arm, all right? Pretty much extended all the way into his fingertips to the point where he had numbness in his hands 24/7. You were taking gabapentin just to get through the day every day. He was told they wouldn't even give him an MRI, right? They wouldn't give you an MRI with any of these kind of things, which is just wild. But what did they tell you about your x-ray? That you had a big compression of?
Between C2 and C7.
Yeah, C2 and C7 were pretty much just compressed and fused together almost in that way. We've only done 6 visits and we've been able to significantly reduce his pain. He doesn't honestly have any really pain today. It's more so just weakness of that nerve, especially like the nerve that innervates that tricep. So he's finding like when he's doing just chest presses and just tricep work, he has a little bit more weakness in this arm. But that's really like, would you agree that's your only symptom you have right now?
Yeah.
Yeah, so we've came a long way. This was actually kind of how a lot of his source kind of started, was inside this kind of scapula. That was where his first symptoms were. It started in here and then he kind of felt it into the arm. And so, you know, whether that be a referral pain pattern, you know, we never really know at the end of the day. But, you know, I think we're still working on strengthening our low traps down into here. And so these rhomboids are going to be overusing and kicking on a little bit more until we build that low trap strength there too. So just show me what we're working with. No instruction. Think about that pencil down between your shoulder blades. You're squeezing that the entire time. And you kind of pull through really well. It's just that last little bit right here, you start to let those shoulder blades go. And so you're gonna lose that tension. So you have to really keep that back the entire time. So then we're back like this, and then we're pulling through that. So remember that first engagement was through the chest. Don't just push up through the arms, everything through the chest. And we stay up like that. We don't let those shoulder blades fall. So I want you really back there the whole time. And I do want you to kind of bring it down that 45-degree angle. And I want you to kind of converge up and in. So they're almost touching. So you let them come out and then converge, come up and in. When you think about your arms and what you're doing with them, I almost want you to think about you're coming up and over that trap. So you set those traps down, you're dropping down to the ground, you're coming up and around it. You're almost like reaching down to the wall and up and over. Okay, trying to come over that joint rather than shrug with that. You keep that down and you come up over that joint. So my traps aren't even involved. I mean, they're isometric and controlling, but I'm thinking about driving my fist down to the ground, then out to the walls as I come up. So drop, out to the sides and up. Much better, significantly better. 2, Yep, and you're just thinking this is tight the whole time. Next patient is in very later stages of a rotator cuff tear, so we're just further opening that thoracic spine and just maximizing the most we can out of those surrounding joints. We then went into some simple internal rotation. I'm really giving him a lot of load with this. It might not look like it, but he's got about 20 pounds. We're just trying to push that as much as we possibly can because this is one of my last visits with him. Again, here we're reinforcing thoracic extension with some active range of motion with that 10-inch chirp wheel where he's extending over it while I give him a little bit of O pressure to really get into that thoracic extension. With all my later stages rotator cuff tear clients, I'd like to implement quick, fast, reactive strength to make sure that they are able to do anything they want in life and they're not going to be inhibited by not having that activation and strength. He actually hurt himself throwing a frisbee, so I want to make sure that shoulder is prepared for anything that he does quick and fast. Next patient up is dealing with a hip flexor tear. Little backstory behind this client. She actually went to an insurance-based clinic where within that clinic, they were dealing with more hip replacements, knee replacements, and they just wasn't getting the PT that she needed. They actually just told her that she had a little bit of tightness in the hip, but that was about it. Upon further testing and assessments, we actually found that she had a pretty severe hip flexor tear. So she'd been able to progress pretty good with some isometrics, but then we were able to load in some eccentrics. With any type of muscle tear or strain, you really want to start out with isometrics. Once those are pain-free, then we go to eccentrics, and then we can go to concentrics where we're actually truly activating that muscle. But we were able to kind of progress a little bit more of her side-lying movements, making sure she's not getting that TFL truly involved, and it's all that glute medius. We then were able to progress her to some sled walks. This is really big for her because walking for her is still something that's really difficult. It is very common for me to get a lot of clients and patients from insurance-based clinics because they're not getting the quality care that they deserve and need, and they're not seeing any progress. So luckily, when I went to school, I had 3 rotations. My second rotation was a cash rotation, cash physical therapy. I recognized this world of treatment and the quality of care that you can give to clients, and I realized I can't go into the insurance world. I would never go into the insurance world. Even after I graduated, I was like, I'm not going to insurance. I had no clients, making no money. It was probably at least year and a half, 2 years out of having my license that I actually started to grow my cash business. It took a long, long time. Even my parents were like, you need to go get an insurance-based job. Like, you just got out of school and you're not making money. Deep down inside, I knew this world. I knew I needed to get into it. I knew my mental health and the quality of my care would be sacrificed with insurance-based therapy. So I chose to not even do that at all. I stuck a little bit more with just honestly social media and personal training and just building my profile and those kind of things. And it's kind of just really led me into a little bit more of this. People have gained trust through my social media, which is kind of like one of the coolest things to me. And it's also really weird because at the end of the day, I'm just little old me and I'm still trying to figure this out and trying to just maximize my business. And so that's probably one of my hardest questions I get is when people ask me, okay, how do you do this? How do you start this? How do you do this? I don't have an answer just yet. I really don't. I'm still learning in the process, and so that's why I wanted to kind of showcase these things so you guys can kind of see, and maybe you guys are picking out things that I don't really recognize are really that cool or really that different, because honestly, I've never been insurance-based therapy. I've done rotations in there as a student, but I haven't been an actual physical therapist in there, so it's very different. And so this is pretty much the world of PT. It's pretty fun. It is what it is, but I love my relationships that I build with my clients. I get the whole hour with them, and the quality of care that you can provide is just time and time again substantial rather than the insurance-based therapy. If you have never tried olive oil in your rice, you're missing out. Of course, I have a little baby olive oil, little baby salt, and you can't forget the hot honey. You just have to try it. It's one of those things that there's a little bit of oil, a lot of salt, and then I like the hot honey over the chicken. A little bit of hot honey over the chicken. So when it comes to documentation within Cash PT, I like to use a software called PT Everywhere. You can do a lot of different things within it, but the one things that I really like about it is, one, it's really easy to do notes, and 2, payment. So I will literally charge this client out right now. Obviously tomorrow's not a business day, so it will be Monday when I would get that income, but I like it because it's immediately right then and there, and there's no credit card fees or anything like that. Don't ask me how, because that doesn't make sense to me, because I don't understand how this platform, I guess I pay this platform monthly. I think it's about $170 a month. So I guess you can count that as processing fees and those kind of things. My favorite part about Cash PT, I'm writing notes for me and my patient. That's about it. I'm not writing notes for an insurance company. So I don't need to come here in my notes. And a lot of people sometimes don't know with insurance-based company and the documentation that you do, you're writing a story to basically tell insurance, hey, I performed this treatment, so reimburse me. So a lot of the times, half the time, people are just basically, it's like this script and you're just switching out ankle for hip. You're switching out Johnny for him. If I was another PT looking at another PT's documentation, it would not help me. That's what I hate about insurance world stuff. Even when it comes to like writing the objective and assessment, I don't even write an assessment. I really just write the subjective, and I write what I did, and I write a plan for next time, or just some things that I might want to work on next time. Of course, we gotta get our fruit and fiber. Well, they're easily my favorite fruit. They taste delicious. They just cost a lot of money, and they go bad really quickly. So you have to know how to wash them properly, and the secret is to letting them dry out after you wash them, so they don't get soggy back at the bucket. And I must inspect every single one of my raspberries because I almost ate a bug last week. It was like actually moving, even after I washed them. Clearly didn't wash them well enough. Actually, I think Donald washed them that time, so that's probably why. All right, so I got about 12 minutes before my next patient comes in. Sometimes if I have this extra time, I sometimes like to do my own therapy on myself if I'm just hanging around. And so this is when I'll do stuff for my plantar fasciitis, or if I ever got hip flexors, or whatever my body needs. I honestly just ask myself, and I check in with myself and say, hey, what do you need right now? I used to do a better job of practice what I preach, and then I started getting so busy to the point where I'm still trying to figure out how to not be so busy, and I slowly feel that slipping away, and so I'm practicing my best to bring it back. Next patient is dealing with some lower back pain, a little bit more into that sciatic nerve and distribution of that piriformis. So we really are just maximizing everything that we can within their thoracolumbar fascia, manual releasing, a lot of these things before we go into further movements. Within these movements, she is a power lifter, so I want to take a look at her squats today. And what we found within her squats is she really wants to kind of forward those knees. So we got to load those hips a little bit more because she does have weakness within those glutes. So getting her to kind of redo that movement pattern and sit those hips back before those knees follow is what we're working on here. The following patient, we work more on neuromuscular re-education. So every single movement that he already does in the gym, I'm just looking to see what can we do to make it more efficient. So for him, he was dealing some with low back pain all the way through the spine. And so we found he really doesn't load his glutes very well. So that's essentially what we're doing here, is getting him to sit his hips back, load his glutes, and really get that connection before he starts to rise up through the back. I gave him a little challenge here with some pulls to try and make sure he really sits those hips back, because a common mistake here is he really wants to let that knee kind of come back into valgus. So putting that pull there really helps that knee and give him an external cue to make sure he has that knee facing towards that fourth and fifth toe and not allowing it to cave in when he comes up. Eventually, I like to see his progression without those pulls. Lastly, here we're just doing some reinforcement from the ground up with some banded abductions to get that foot firing. Last patient of the day is a personal training client. We're doing a full body strength day. So first we started with some sumo deadlifts and then went in some rotational chest presses. Trying to just really incorporate some chest, because a lot of bodybuilders do not incorporate chest, and that is her goal, is to do a bikini competition. So we want to make sure she has a full rounded body and we're not just focusing on shoulders and glutes. So then we went to some deadlifts or some RDLs here. She, again, has a kind of hard time with a lot of people not sitting those hips back before those knees. And then last off, we added some external rotations with a cable, really just trying to maximize those small stabilizing muscles before we build a strong foundation of the shoulders and back. Alrighty, y'all, that is it. That was a full day in the life as a cash physical therapist. We saw about 7 clients. I typically don't really like to see more than 5 or 6, but I only work 4 days a week in person. My online clients are on the weekend, so I'm okay with taking a little bit more in person during the week if they have to and if they need to get in. If you guys found this video helpful, you want to see a little bit more about just cash physical therapy, different patient presentations, or more examples, or more treatments, whatever it may be, please leave a comment down below. And as always, be sure to like and subscribe. And thank you guys so much for following along with this vlog style content. Appreciate you. See you on the next one.